Talk about the Endangered Heal, about prevention and treatment for heel pressure injuries. My name is Pamela Scarborough. My credential is as a physical therapist. I'm also board certified as a wound specialist. I was a diabetes educator for over 20 years. I let that credential go. And I love what I do. As Jacqueline said, I get to teach our onboarding physicians, our onboarding nurse practitioners, physician assistants. We have our fellowship program, which is the only mid-level fellowship that we know of in the country for our physician assistants, our associates. The name has changed to physician associates, and our nurse practitioners. So I love what I do, and I'm very grateful that you're here today and that I get to share some information with you. Some of it's a little bit new when we talk about the heel. So I need to get going because we've got a lot of content to do, but I have to do this. Our attorney insists on it. I have to read this disclaimer. This information is provided for informational purposes only. Patient management decisions should be based on a number of factors, including, but not limited to, professional society guidelines and published clinical literature relevant to a patient's condition. Providers are encouraged, and when we say providers in this context, this means facilities, long-term care facilities, it means home health, it means any place that's serving patients and residents. Providers are encouraged to rely on their training and expertise. Where did you get your training and expertise regarding wound prevention and management? It takes a very large body of knowledge to be able to do this well. This is a specialty in healthcare. It is wound medicine is what it is, as well as any and all available information prior to making management or treatment decisions for any individual patient. These are two of the resources that are going to be provided for you. The National Pressure Injury has a heel pressure injury guidelines. That just came out in 2025. We're going to give you that, and we'll also give you the F686, which has some things to say. Our objectives today is at the end of this program, you should be able to identify heel anatomy and physiology related to pressure ulcer injury development. You should be able to list some of the primary risk and causative factors for the development of heel pressure ulcer injuries, and to be able to discuss some of the current recommendations for both national and international guidelines for the prevention and treatment of heel pressure ulcer injuries. So when we talk about heel pressure ulcer injuries, the literature lists both the sacrum and the heels as being the most frequent locations for pressure injuries due to the high pressure, the limited padding in both of these areas, positioning, and poor angiosome vascularity. And we're going to talk about angiosome vascularity as we go forward. So both of these sites are being most frequently listed as where we get our pressure injuries, and these two sites are where most frequently we get our deep tissue pressure injuries. They're most often on the sacrum and on the heels. So when in long-term care, the literature tells us that usually the heel is the #1 site. And in most other care settings, the heel is the second most common site. And it doesn't matter. It goes back and forth. Heel, sacrum, heel, sacrum. That's the two places we get most of our pressure injuries. And about 41% of the deep tissue pressure injuries, almost half of the deep tissue pressure injuries, are on the heel. And the literature tells you 80 to 90% of these are avoidable. I've got to tell you, if you got that heel floating, 100% are preventable. If it's floated 24/7, which is very difficult to do, very difficult to do. And then we have about 24 to 30%, again, of the pressure injuries develop on the heel. And the second place is going to be the sacrum. Now what we're going to do is we're going to go through some of the risk factors. And a lot of the people that come on these programs that I do, we get providers, we get physicians, nurse practitioners, physician associates. A lot of the people are nurses, and a lot of the nurses are doing some of the assessments originally. And I want our nurses to look at your assessments for pressure injuries, specifically on the heel, but for pressure injuries in general, more comprehensively. We have to go beyond the braiding. If we only do the braiding, then our pressure injury prevention program has already failed because we have over 100 risk factors. So my question to you is your facility considering all of the following risk factors for heel pressure injury? So let's look at this. So we're going to review these factors. And if you're the person that does this assessment, you want to ask yourself, or if you are over the assessment, I saw we have some DNSs on here, some DONs, directors of nursing. Is your team looking at all of these risk factors related to the heel? Because those are also, the heel pressure injuries are hard to heal, HEAL, especially in the presence of some of the comorbidities, particularly peripheral arterial disease. So you want to look at the anatomical structure. We have minimal subcutaneous tissue, and we're going to come back to some of this in a little while. We have a very small surface area that the heel is resting on when it's on the bed or the plinth. The shape of the calcaneus, we're going to go through that in some detail in a few minutes. And then the heel fat pad is very vulnerable to compression and shear. It's mainly on the bottom of the heel. The heel fat pad is mainly on the bottom of the heel. It goes a little bit towards the back, but mainly on the bottom of the heel. And then we have our biomechanical and positioning factors. Supine, supine, supine. These people are laying on their back. And we're going to talk about plantar flexion and the heel rim in just a few minutes. There's direct pressure on this that's perpendicular to the bone. Right where the calcaneal tuberosity is located. I'll show you that in a few minutes. And then it could be that we had prolonged contact with some type of a support surface. Maybe it was a bed. Maybe it was a stretcher. Maybe it was an OR table. And then there's inadequate offloading or repositioning taking place. So these are some of the risk factors related to biomechanical and positioning. Then we have mobility and that person's clinical status. Anyone who has limited mobility is going to be at risk for pressure injuries. That's all there is to it. Mobility, mobility, mobility. What is your patient or resident's mobility? And have you scored it appropriately and correctly? If they're critically ill or in the long-term post-acute care setting, we have people with multiple comorbidities that are in the chronic multi-organ impairment or even multi-organ failure. And these people are going to get unavoidable pressure injuries, which we also know as skin failure. And sometimes they're truly a pressure injury that you had to position the person in a position that created that pressure injury, but clinically you had no choice. Just have to be sure you document that well. And then we have prolonged supine positioning, again, ICU, OR, diagnostic procedures, and then maybe the early phase after a spinal cord injury. And then we look at tissue tolerance. Tissue tolerance is different from every single person, just like your fingerprints are different for every single person. And many people do have that heel fat pad atrophy. They may be frail, older adults, and they may have reduced tissue resilience because of their age. And cushioning to the skin changes that takes place, the thinning skin, the drugs they may be on, particularly steroids. When we look at risk factors, think about vascular and perfusion. And this is something that we should all be looking at. Nurses, all of our nurses need to be looking at this when they're doing their head-to-toe skin assessments. You may not be doing an ankle brachial index, but you're looking at some other things from a vascular perspective. Peripheral arterial disease is very, very common, particularly in our older adults, and very specifically in long-term care and post-acute care settings. We have a lot of peripheral arterial disease. And then with that, we get reduced tissue perfusion. So this person is not able to tolerate the pressure. Anytime there's decreased oxygenation anywhere in the body, including systemic oxygenation, how's that heart functioning? How's that heart pump working? When we have decreased cardiac output, it decreases the blood to the skin. And I'm not seeing cardiac output numbers. I don't know why we're not seeing those numbers when people have those numbers. And then sensory impairments, such as from peripheral neuropathy, because that person has diabetes, or they're a spinal cord injury, or they have a reduced ability for some time either to perceive pain or to express that they're having pain. Some people are aphasic. Some people cannot express to you that they are having pain. Some mechanical forces, again, we go back to immobility, medical devices that are put on inappropriately. And when we talk about the heel medical devices, we have your heel protectors that may or may not be put on correctly. I've seen them put on literally upside down. They've been turned the other way. And then pillows. You can use pillows, but not if they're poorly positioned. And we'll talk about that positioning. Shear forces are very important when you're putting that person's head of the bed up and their heels are scooting down as the head of the bed comes up. They have friction and shear when that happens. And their sacrum, when they slide down, you brought the head of the bed up and they're sliding down, and you're going to get shearing in that sacral area of those soft tissues as the bed sticks, the mattress, the body sticks on the mattress, and the underlying tissues begin to torque and slide. That's called shear. And then we talked about a little bit about advanced age contractures are a risk for heel pressure injuries. If that person is in a contracture with their knee bent and or their ankles contracted, where you have more pressure on the heel area, maybe even the lateral side of the heel, not necessarily the posterior side of the heel. Nutrition and hydration deficits, when they don't have enough fluid on board, enough nutrition on board, enough protein on board, they're at higher risk for pressure injuries. And lower extremity edema is also going to put them higher, particularly if it goes down to the foot, at higher risk for pressure injury. So the bottom line is heel pressure injuries occur when high focal pressure meets poor tissue tolerance, especially in patients who are immobile, they have a vascular compromise, or they're unable to feel or their discomfort. They're insensate and they cannot feel that they're having pain. So the heel doesn't have the same protective capacity as other areas in the body. And when you combine immobility, poor perfusion, and loss of sensation, it becomes a perfect storm for acquiring a heel pressure injury. But the number one reason for heel pressure injuries is immobility. Everything else is a contributing factor, and you want to pick up all of those contributing factors. Have you done that? This is a statement from F688, which talks about the assessment for mobility. And you want your physical therapist, and which is what I am. My doctoral is in physical therapy. I have a bachelor's and a doctoral in physical therapy. So it's your physical therapist should be part of your team helping you to assess mobility, unless you're doing your GG section perfectly in the MDS, and you're assigning the numbers that go along with the immobility related to sitting and standing and rolling and holding positions, that kind of thing, getting on the toilet, all that. If the nurses are doing this and they know how to do this, to give that numerical component for risk for pressure injuries in long-term care, then you may not need your therapist. But in many buildings, the therapists are doing this and reporting it to the MDS coordinator, which is really what I like to see, because the therapists are trained from the get-go to assess and give numerical, more objective measurements for immobility, range of motion, strength, that kind of stuff. So when you look at this, the resident needs a comprehensive assessment that looks at their mobility status, that looks at any limitations, and if there's any opportunities for improvement. And again, that's where your physical therapists come in, so that they can help you figure out some of this immobility issues and what can be intervened for and what can't be intervened for. Sometimes we can't intervene. And then the MDS also process talks about this is what I'm talking about when we're looking at the MDS. Can this person go from from sitting to lying, or from lying to sitting? Can they turn side to side in the bed? Can they reposition their body? Can they do transfers safely between the bed and the chair, or standing and walking? So this comprehensive assessment needs to address whether the resident has previously received treatment and services for mobility, and whether he or she has maintained their mobility, and whether there was a decline, and why the treatments were stopped. Why did we stop with mobility? Maybe they've gone on hospice. Maybe they've gone on palliative care and they don't want to move anymore. There are reasons to stop doing all kinds of interventions. So this is a great section for your therapist and your nurses to read, F688, when it talks about the assessment for mobility. And look at your GG section, nurses. That gives you a lot of great information also in the MDS. So the anatomy and physiology, we've alluded to this a little bit. So let's look at the heel. So when we're continuing, I want you to think about a person laying in the bed. They're laying on their back, just like you see this person, and this heel is on the bed. Heels on the bed. So as you look at this entire bone right here is called the calcaneus. On the back side of the calcaneus, right here where this triangle is pointing, there is what's called the calcaneal tuberosity, and that's where the Achilles tendon takes your soleus muscle and your gastroc muscle. They come together into the Achilles tendon and they insert right there on the calcaneal tuberosity. There is a little bitty bursa under there. There is no fat. There's no subcutaneous tissue. You have some fat padding right here on the heel. You see right through here? There is a fat pad here, but it decreases with aging and decreases even more in the presence of peripheral arterial disease. So many people's fat pads are not working very well for them. So that calf, when you look at the calf, where it is, that calf may or may not take some of the weight of the muscle bulk. And if not, then when you look at the weight of the leg and the fluids in the leg, the muscles in the leg, the bones in the leg, all of that weight is resting on that calcaneal tuberosity. And most people, not all of them, but a lot of people's feet will roll out this way. That rolling, it doesn't happen at the ankle, it doesn't happen at the knee, it happens at the hip. Their legs are straight, and their hip range of motion, when they go like this is happening at the hips primarily. So, and a lot of times you'll see those lateral heel pressure injuries because their feet roll out this way a little bit due to how their hips are structured, is the reason that happens. So this it's a very, very high risk point for a pressure injury just by its anatomy and physiology. Then, well, wanted to bring this. This came out of the National Pressure Injury Advisory Panel. This comes out of the brand new document. I just gave y'all are going to get that document tomorrow, and please read it because a lot of this content is in that document. So when you are laying down, when a patient or resident, even you, I was practicing this in the bed this week when I've been in bed thinking about this. When you lay down, then the supine position, your foot naturally falls into plantar flexion at the ankle. That range of motion, of course, is taking place at the ankle. So your foot goes down into plantar flexion, just laying there normally. And so in this drawing, look at the feet, assuming that plantar flexion position, which worsens when we put covers over the feet. The covers push that foot even down into more plantar flexion and puts more weight on that person's feet and pushes their feet more firmly into the bed surface, creating additional pressure to this vulnerable area. So you can see here the foot's going into plantar flexion, and when that happens, more of the heel towards the fat pad will also begin to get some of that pressure. And the covers are, and they showed a pillow under here. This is not how you do your float your heels. You do not put anything under that posterior aspect of the heel. You want a little bit of distance, and we'll talk about this some more. But what's important is that these feet are assuming this plantar flexion, which gets worse as the covers press down and adds more weight and puts that foot more firmly into the bed, creating more opportunities for your heel pressure injuries. I want you to think about the blood supply to the lower extremity. We have to understand our anatomy and physiology. Oh, and by the way, there's a CNA on here, and I want to say thank you so much for being here, because our CNAs, they are precious to us. They do 70, 60, 70, sometimes 80% of the task is on their shoulders for preventing pressure ulcer injuries. It's on the shoulders of the CNA. Rarely do I get any CNAs on here, so I'm so grateful you're here today. And whoever let the CNA come, thank you. And be sure you tell whoever let you come, thank you from me, because it's important that you're here. And with that said, the primary blood supply to the heel comes from the posterior tibial and peroneal arteries, not so much from your dorsalis pedis. The dorsalis pedis goes to the forefoot. It has nothing to do with the hind foot. That is going to be primarily your posterior tibialis. So when we are, which goes behind and below the medial malleolus. So this is what you're seeing. This is your posterior tibialis right here. And when we do ankle brachial studies, we do both. We do the dorsalis pedis, but you have to do the posterior tibialis because that's the artery that goes to the heel to make sure that you have enough blood flow. So the peripheral arterial disease with the thinning of the skin, the subcutaneous tissue, the aging, the decreased blood flow, all this puts this foot, this heel, at risk, more at risk for a pressure injury on the heel. And that's just showing you the dorsalis pedis. And then right here is your posterior tibialis. This is another artery, but this is the other artery is not one that we do our ankle brachial indices with. So the heel pressure injuries, they're different from pressure injuries on other parts of the body. Your number one concern, besides offloading, floating that heel, the number one concern is blood flow. Do you have enough blood flow in that leg for that person's heel wound to heal? One of the problems is we don't have enough, we have fewer angiosomes. We were never meant to lay down and keep laying down. And I lay down all night, you lay down all night, you don't get heel pressure injuries because we're moving, we're mobile, usually even during the night. But well, we'll talk to you about angiosomes in just a moment because we have fewer of them. And the angiosome, when I speak about angiosomes, that's the terminal blood flow to the skin, not capillaries. It's angiosomes. So we want to have that heel floated 24/7 if they're in that bed, if they're laying down in the bed, supine. Now your angiosomes, when you look at this with me. Oh, I love that new pointer. I made y'all a nice big pointer so you can really see what I'm pointing at. So this is what's called an angiosome. It's the skin territory. This is a source artery right here. And then it goes into the capillaries, and the capillaries then go into the skin. The terminal blood flow to the skin is in the angiosomes. And so if you've ever studied your flaps and grafts, the plastic surgeons, they take a area of skin with a source artery, and that source artery takes care of the capillaries and the angiosomes to the skin, and they'll move it. But they take that whole section of skin with the vascularity, that goes to the skin. So the terminal blood flow to the skin is in the angiosomes. And there are some differences in other parts of the body. The sacrum and the heels have poor angiosome coverage. That's part of our anatomical risk. You didn't know that. I didn't know that until 3 years ago. Part of our risk for pressure injuries on the sacrum and the heel is because we have less anatomical blood flow to those areas. Because whoever made us never intended for us to stay laying down like that. So we shouldn't even be getting pressure injuries, but we are laying down like that. And that's why we're getting them. So we have fewer cutaneous perforators from the lateral sacral artery that supplies a single sacral angiosome as compared to the buttock. When you look at the buttocks, the gluteus maximus muscle, there's about 40 angiosomes on each side. The sacrum has one coming from this lateral sacral artery. Compared to the numerous vessels supplying the multiple buttock angiosomes. So this is the bottom line here. Both the heels and the sacrum are predisposed to injury from pressure due to fewer angiosome distribution in these areas. And just a very quick case study. This is a lady that came into one of our long-term care facilities. She had fallen, she fractured her femur, and they did an ORIF, open reduction internal fixation. She came into a long-term care facility. This is the first, and I want y'all to answer in chat. Please answer us in chat. Looking at this, what would you call this? What would you call this? I know what I call it. It's over on this screen. I know what I call it and looking at it. I have it in my mind. I'm just looking at this. This is all I know, that they were in the hospital, that had surgery. This is all you know coming in. What would you call that? Somebody put it in the chat. Let's see what you have in the chat. Put it in the chat, what you think it is. All right. I'm seeing DTI for most people. And I see also a stage 2 with a question mark. And I understand because it looks a little bit like a blister. I do understand that. So she comes in with the diagnosis of a deep tissue pressure injury. Her skin was warm. They could feel the pulses. This was the first time the nursing home saw it. The hospital said that the person was offloaded during their surgery, but the patient did complain of significant pain. So they started physical therapy, and which is what they should do. And what happened is over a week's time, the pain in the foot, that she was having pain in the foot and pain in the heel, it got worse and worse. And finally, the physical therapist said, stop. There's something wrong here. You should not be having increasing pain the way you're having increasing pain in the foot. Even the arch of the foot and the dorsum of the foot was hurting. So they stopped it. One of our providers came in and they did us looking at just some O2 saturation with a piece of equipment they had. And this is what they saw right here. Now, the provider, the physician associate, said, based on what I have with this machine, this near infrared light is what they were using. This person has severe peripheral arterial disease. I think she needs to go to the hospital and to the ER right now. And they sent her to the ER. They did an angiogram and she had critical limb ischemia. If our provider, if I'd not just given the talk over the angiosomes when I first got there in 2024 with this group, she would not have known this. Angiosomes are important to you. They give you important information. If you're clinical and if you are doing assessments, angiosomes give you important information. You want to learn them. So they had to put a stent in. So this is what she saw on the near infrared imaging. Excuse me. Then this is the angiosome pattern for the calcaneal branch of the perineal artery. Look at what this thing turned into. It started like this. Looks like a DTI. Absolutely. If you said DTI, I'm right with you. If you said stage 2, I understand why you said it. DTIs don't create panhandles. That's not what they do. There's no pressure up here. The pressure, if there was pressure, it was down here. So this is something else. And look at what it is. It goes right along this calcaneal branch of the perineal artery. So they got her stent put in, 8 weeks of sharp debridement, a standard of care dressings, Progenimatrix, which is a cellular and tissue-based product. This is before the stenting, after the stenting, and she's going to be closed. Had we not had this conversation, this woman would have lost her leg. Now, when these things come up, when this comes up, just put in the chat, what stage do you think this is? We're doing this for fun. This is a reminder. If you've been on these programs before, you've had this staging before. So there is some vascular surgeons that wrote a paper, and these vascular experts suggested that your stage 1 and 2 pressure injuries may heal with moderate peripheral arterial disease. But your stage 3 and 4 heel pressure injuries will not heal without pulsatile blood flow. So when you're doing brachial indices, that gives you a number. The blood flow is going to be your waveforms. You want to look at your waveforms. If you're a clinician and you're looking at ABIs, you've got to look at those waveforms. Is it triphasic? 3 sounds. That's great. Biphasic? Not so great, but we still have forward blood flow. And you have these waveforms. You have your triple waveform, you have your double waveform for biphasic, and you have your single waveform for monophasic. And when you get down to monophasic, you have no forward blood flow. So you always want to look at your skin perfusion waveforms. That's going to help you. So the vascular study that we most use in outpatient our post-acute rehab, our post-acute settings is our Doppler. So blood flow is extremely important. And what did somebody say about this wound? They said it was unstageable. This is actually, it is a stage 4. Right here, I guess I should have given you a thought. That is bone at that place. So the perfect storm for the person most likely to get a pressure injury on the heel is where they have marginal blood supply to the foot and the heel from peripheral arterial disease. They have thin skin and adipose tissue, which is common in our older population. And then the shape of the heel, everybody's shape is just about the same of the heel. And then also the person is supine. They're laying in the bed all the time. These heels need to be floated. And without external interventions, this person will most likely get a heel pressure injury. So without external interventions, yes, this person will most likely get a heel pressure injury. So this is just showing floating. This is none of our patients. Look at those perfectly manicured toes and those beautiful young legs. Not any of my patients, but I get the premise. The premise is we have to float the heels. We have to float the heels. No exceptions, no excuses. It has to happen. And if the patients cannot keep their heels in a device or floated, you want to document it. Or else, if you're in long-term care, you'll get an F tag, maybe followed by a lawsuit, which could happen in any care setting. So it's very, very important that you have a team. These are the facilities, the buildings, the hospitals that have had the most reduction in their pressure injuries is when they have an interdisciplinary team. No one person can do this by themselves. No one CNA, no one nurse, no one physical therapist, no one physician, nurse practitioner. No one person can do this. It requires an interdisciplinary team that talks to each other and communicates with each other. And there needs to be, if possible, resident participation, if they can, and understanding your multi or interdisciplinary team and integration of all the clinical reports. All the clinical reports need to be showing together that we're doing everything we can to prevent these pressure injuries. So this requires an organizational culture and organizational practices that promote teamwork and communication, as well as individual expertise in preventing pressure injuries. And this improvement in pressure injury prevention, it calls for a system focus. It's not for one person. You have to form up your system. And that's the first course we did in this series, was talking about how do you create a system that is functional, and what are the key components that need to be in that system. So again, no one can do this alone. And many organizations, sometimes it takes them up to a year to reframe everything and to get all their policies and procedures. And that is a big hole, particularly in long-term care and home health. We're not seeing policies and procedures related to how we do certain practices, such as skin assessments, dressing changes, including infection control. So we have some holes in this. And when we don't have these policies and procedures, it's hard to train newer people. And we have a lot of turnover in healthcare, particularly in long-term care. So you're going to have ongoing assessments. The National Pressure Injury Advisory Panel talks about removing the devices on the feet and having regular, somebody looks at the feet every day, at least daily, and more than once a day if a person is at high risk for skin breakdown. And some things you just do not do. You don't put on TED hose. TED hose are for people are at risk for DVTs. They don't help edema, and they don't prevent swelling. They don't help swelling. And they're dangerous, particularly at the anterior ankle. At the anterior ankle, where those TED hose always wrinkle, and we can have very poor vascularity. The anterior part of the leg is part of the leg that has some of the least blood supply to it. So it's quite common for TED hose to cause medical device related pressure injuries. That's what I'm talking to. So we need to be careful with that. We want to use support stockings appropriately and have heel protectors or suspension devices for the heel. And again, the best practice is to remove these things and look at that heel at every shift. Every shift. You want to, so take a look at this. Let's see. So we did unstageable. All right. So what is this? Which stage is this? So you want to inspect the skin for erythema in individuals who who have been recognized as being at risk for pressure injuries. And if possible, you want to try to be sure you don't put anybody, you avoid positioning a person on areas of erythema or redness. So what stage is this? Oh, excuse me. It is a stage 3. It is a shallow stage 3. It's a shallow stage 3 because we have granulation tissue. We have slough and granulation tissue. And that's the point. In some areas on the body, you can have a stage 3 or stage 4, and it's very shallow. When you're staging is about tissue destruction. Please hear what I say. Staging is about the amount of tissue destruction. It's not in centimeters or millimeters or inches, and we only measure in millimeters or centimeters. So this is a shallow stage 3 over the heel. You want to avoid positioning a person on erythema if you can. So let's look at this one. Please stage this for me. So let's see. This is talking about a stage 2. It says that we're supposed to examine the area adjacent to or surrounding an intact blister. And this comes out of the MDS. If you look at my slides on the top left corner, a lot of the times you know where this information came from. So this came from our MDS, the minimum data set for long-term care. It says if other conditions, let's see, you're looking for blisters, and you're looking at intact blisters. If other conditions are ruled out and the tissue adjacent to or surrounding that blister has signs of tissue damage, such as color change, such as bleeding. If you have bleeding under the skin, tenderness, bogginess, firmness, or warmth, these characteristics suggest a suspected deep tissue pressure injury rather than a stage 2. Stage 2 ulcers will generally lack the surrounding characteristics found with a deep tissue pressure injury. So what did y'all think this was? Yes, somebody got it. Beth got it. It's a deep tissue pressure injury. That's what you've got right there. All right, very good. All right, I've got another one for you. What stage is this? So when we're looking, you want to look at erythema and where you want to blanch it. If your erythema blanches, then your skin is still intact. It doesn't have a stage 1 pressure injury. So that's one of the things that you're looking at. When you look here over the left, this is showing structural damage to the capillary bed, to the microcirculation. So, and this is, we have angiosomes here too. We have angiosomes in every part of the body. So what stage? And somebody said they didn't give me a stage. Okay. So this is a stage 1. And what you're seeing is this is not a stage 1. This is blanchable erythema. On the left here, I just misspoke. Let's get this clear. This is a stage 1 pressure injury. This is blanchable erythema. So that is not a pressure injury. The microcirculation is still in place because it will blanch. But over here on the left is a stage 1. So you want to blanch every heel. Non-blanchable usually means that you have a pressure injury patient in the area. So this, you can do it with your thumb or your index finger. Thumbs are stronger, of course. That's the finger pressure method. Or one of the ways I love it, I really love it, particularly in people who have some arterial insufficiency and they're not blanching very well, is to do the disc, a plastic disc. It can even use a plastic cup. Just anything you can see through. You want to blanch it to see if there are problems. And our CNAs, in my mind, they could do blanching. It's a screening tool. They can do blanching and then report that information if it's positive for a pressure injury, stage 1 or a deep tissue pressure injury, then report it to the nurses. I feel like CNAs can do a screening situation such as that. You want to inspect the skin regularly. And this is talking about these nurses in England. They do a great job in England. Their community health care they do a very good job. And so what they're doing here, all these nurses in England, they all have mirrors, and these mirrors provide a reflective surface, and that reflective surface actually gives you more light. And if you're over 40 years old, like I am, you've already lost a lot of your dark or acuity. You can't see as well in the dark. So the mirrors actually help coalesce light. Even if you don't have, if you're not over 40, it still helps. The mirrors help to coalesce light so that you can see these heels better. And the other thing, and I love this, you don't have to lift that leg up as high. You slip that mirror under there and it saves our nurses and our CNAs backs. Most of my back patients, one of the last outpatient hospital that I was working in for physical therapy and wound care, most of my back patients at that point in time came from the hospital nursing team where they'd injured themselves trying to take care of their patients. So provides methods for examining skin and hard to heal, hard to see areas without having to maneuver those immobile patients that can hurt our backs. So again, you want to float the heels. That's the term, floating the heels. You want to use your suspension devices. And if you use these suspension devices, you need to make sure that they distribute the weight all along the leg, all along the calf without putting pressure on the Achilles tendon. So this is someone that was lifting the leg or whatever they were doing, and we have a pressure injury on the Achilles tendon. This is your two big calf muscles. You're going to lose the efficacy of these calf muscles if you lose that tendon. Those calf muscles are going to roll right up that leg, the gastrocnemius and the soleus muscles. So this is showing what you're seeing here. Let me go back to here. It's showing that there is this heel is floating in this device and that there is pressure redistribution all the way up this lower leg. And then here we have, when we look at, these are our recommendations for heel suspension devices. They're preferable for long-term care, are for individuals that, for long-term use, are for individuals who are unlikely to keep their lower extremity on the pillow. And we need to look at the manufacturer's guidelines and make sure you put these things on correctly. They're not that hard, but I told you, I saw them put on upside down. They'd taken this part of the leg, the part that went to the foot, and put it up on the leg, and the part that went on the leg went down on the foot. And they weren't getting their outcomes. We need to look, you make sure you know how we're putting these things on. So some devices are not appropriate, such as if they have supports with metal bars, we need to be very careful with that in the bed, in the chair. Special care for observation of patients and residents with contractures. They're going to be higher risk for pressure injuries when they have contractures. There's always going to be a mobility issue for people with contractions. Or that have decreased sensation. They're going to be at higher risk for pressure from these things like metal supports or metal struts that they may have to wear for some type of medical device. And many people cannot communicate their pain or discomfort. And how are you assessing that? So pressure redistribution support surface is not adequate to protect the heel. Even though that person might be on a low air loss bed, pressure redistribution mattress of some type, you still have to float the heels. That bed does not take the place of pressure redistribution for the heel. So recommendation is to offload the heel even when they're using a pressure redistribution mattress. Float those heels, even on a support surface. Also, the recommendation from the National Pressure Injury Advisory Panel is that we have a slight flexion in the knee, 5 to 10 degrees. And the reason is in the popliteal area, we have here's our tibial nerve, here's our popliteal artery, and here is our popliteal vein, both artery and vein, popliteal artery and vein. And these come right behind the knee. When the knee is stretched, is extended, and you have the heel up on a pillow, let's say you have a heel or even the Achilles tendon area up on a heel, you hyperextend that knee. You don't want to hyperextend the knee. You want it bent because there is a question about if we cause more DVTs when we have the knee situated like this. And there is a question that we may be causing more DVTs. So you want to protect the Achilles tendon to avoid areas of high pressure. Use foam cushions under the full length of the calf. If you're going to use pillows under the full length of the calf. Pillows or foam cushion used for heel elevation should extend the length of the calf to avoid areas of high pressure, particularly under the Achilles tendon. We're having Achilles tendon pressure injuries, and it becomes a big problem if they lose that Achilles tendon. So what are you looking for? If you're going to buy heel protectors, what are you looking for? You want heel protectors that are going to separate and protect the ankles, maintain the heel suspension, prevent foot drop or plantar flexion contractures. And that's what this strap is here for, is to pull that foot up into dorsiflexion a little bit higher. Bring that foot up into dorsiflexion a little bit more. And the exterior, this is one of the things that we cannot do with pillows. But these materials that we have now for these heel suspension devices, the textile, the material on the outside is slippery. So that person can actually move their leg, slide their leg within the bed a little more easily, giving them some freedom of movement. And this is important to them. There's pressure redistribution within that calf. It's ambidextrous. It goes on a right leg or a left leg. It holds that foot in a neutral position without that external rotation that I talked to you about that comes from the hips. We don't use donut shaped devices. We should not use synthetic sheepskin, but I will tell you that real sheepskin does decrease pressure injuries and helps healing with pressure injuries. I actually have experience in that, and it was blew me away. And the NPIAP actually says that natural sheepskin pads might assist with preventing pressure ulcer injuries. And my mother had one in many years ago while I was still in school, and I didn't know what to do about it because I was still in school. My grandmother was taking care of her, and there was a nurse who was a friend of ours, and she said, "Pamela, go buy sheepskin, and that will probably work." My grandmother was too old and could not roll my mother up. I was in Texas, my grandmother's in Louisiana, and sure enough, my grandmother put that sheepskin on there, and my mother's pressure injury. She's totally immobile. She's paralyzed. Everything except for one finger is paralyzed, and it healed that pressure injury. So I wanted you to know it might assist in preventing pressure injuries, and it might assist in healing pressure injuries. So that's something to consider if you can't get a bed for whatever reason. Pillows, if you're going to do pillows, it has to be done like this, where the entire calf is redistributing the pressure off of the heel. You don't need a lot. This is just, they probably have a half an inch of distance between the bed and the heel. That's all you need. That's all you need. You don't need a lot of distance. And then look at the knee. The knee is also in that 5 to 10. And this is, if you're going to use pillows, this is how you do it. But here's the thing about pillows. I don't know if they're any better now in 2025, but when I was in long-term care, my pillows in my facilities, they were flat pillows, flat pillows. I don't know what it is that we sell flat pillows to all nursing homes. So if you have plumper pillows now, I think that's fabulous. I've never had a plump pillow in long-term care. NF686, it says that because the heels and elbows have relatively little surface area, it's difficult to redistribute the pressure on these two surfaces. Therefore, F686, State Operations Manual, Guidance to Surveyors for Long-Term Care, says it's important to pay particular attention to reducing the pressure of these areas for the resident at risk in accord with the resident's overall goals and condition. And pillows used, so here it is in your regulation if you're in long-term care. Pillows used to support the entire lower leg may effectively raise the heel from contact with the bed, but the use of pillows needs to take into account the resident's other conditions. Can they keep their feet on the pillow, their legs on the pillow? And that we do not use donut cushions. Those are not recommended. So what stage is this? And I will tell you that these are little white blisters is what that is. And I'll come back to see how you did on the quiz. So it'll relieve pressures under the heels with a stage 1-2 pressure ulcer by placing the legs on a pillow to float the heels off the bed or by using heel suspension devices. Now this came from their 2019 clinical practice guideline. I didn't see it in the new one, and I liked it so much I kept it. So there'd be some things with the new clinical practice guidelines that you might think, well, they're not recommending that anymore. Well, even if they're not, I like the statement, so I kept it. So what stage do we have here? I'm looking over so this is a stage 2. Thank you very much. Good job, Nelson. All right, so stage 3 and 4 in unstable pressure ulcers, they need to the recommendation is to place them in a device. And again, this comes from 2019. The new is a little bit different, but I thought this was very important, so I kept this. Place the leg in a device that elevates the heel from the surface of the bed, completely offloading the pressure ulcer. If you have a stage 3 or 4, do not trust your pillows. I'm not going to trust my pillows. I'm going to get a device when we have a 3 or a 4. And consider a device that helps prevent foot drop. So elevation of the heel on the pillow is usually inadequate for stage 3 and 4 pressure injuries. And dressings. How many of you has anyone heard of using dressings to prevent pressure injuries? Just raise your hand if you've heard of using dressings to prevent pressure injuries. And I'll look back over here in just a moment. I see a hand go. Oh, there you go. I do see hands going up. There is, that is something. The evidence isn't high, but there is probably about moderate evidence because some of these studies were done in ICU. So let's talk about prophylactic dressings. But first I have to tell you, CMS doesn't pay for it. Nobody pays for it. It's going to come out of pocket, out of your own pocket, whoever is taking care of these people. So you want to use prophylactic dressing as an adjunct to heel offloading. An adjunct. They do not take the place. It's if the heel gets on the bed for a few minutes, that's what it's for. It's you don't want to use foam as your primary method of preventing a heel pressure injury. Offloading and the foam. So the 5-layer foams applied to the heels have shown to help reduce two contributory forces for the pressure injury, and that's friction and shear. Through this multi-layer construction, it has 5 layers. This construction protects fragile skin from shear, the shearing that goes between the layers. Some of the shearing happens, and the friction, some of the shearing happens between the layers, and then on the very top or the bottom, whichever way you're looking at it, the top layer that's facing out of the foam is reduces friction. So you reduce both friction and shear with these 5-layer foams. Also, it influences microclimate. It helps with cooling. You have what's called your moisture vapor transfer rate with this type of foam, and it helps to influence the microclimate so the person doesn't, their skin doesn't get as moist and as warm. Moisture and warmth is what's called microclimate. Moisture plus warmth. It can be sweat, it can be exudate, it can be anything that's moist. Moisture and heat are microclimate, and the collagen becomes more vulnerable when you have an increase in your microclimate, which is moisture and heat. Research shows using prophylactic dressings along with the heel offloading result in fewer pressure injuries than using it without the dressing. Use a prophylactic dressing as an adjunct to heel offloading and other strategies to prevent heel pressure injuries. Foams do not offload direct pressure forces and is not a replacement for floating the heels. And so these are the things they do at moisture, the mechanism of action of the 5-layer foam: moisture wicking, temperature regulation, which is your heat and your moisture, and then it also helps with your friction and shear reproduction. So a note here: the heel pressure injury prevention care plan must be comprehensive. The foam will not prevent pressure injuries in the absence of offloading or floating the heels when the resident is on their back. The foam, multi-layer foam, will not take the place of turning and repositioning, will not take the place of thermal or skin moisture control. That's part of what the CNA, and because I have a CNA, I want to say this because I just love it that you're here. When that CNA or whomever rolls that person off their back or whatever side they're on, you also are getting cooling. It's not just taking the pressure off, it's also working with the microclimate. And when you roll them over, you might even take the covers. If you notice or feel their back is really warm, you cool that skin down so it's not as vulnerable to breakdown because of the moisture and the heat. So that's very, very important. That's your number 3: thermal, skin moisture control, and other care and preventive interventions such as nutrition and hydration, that kind of stuff. So treatment of existing heel pressure injuries, you're going to follow the general guidelines for wound care, but it's not limited to offloading. You've got to keep that heel offloaded. You want to do frequent repositioning. You want moist wound healing practices. If you have a wound there, you're going to have to do debridement if there's necrotic tissue, prevent infections, treating chronic inflammation, which we can do both of those. Well, preventing infections, we're going to do that with what we're talking about by preventing wounds, for one thing. And then you're going to have great infection control practices when you do dressing changes. You want to keep that wound moist using the dressing selections, compression for venous insufficiency and lymphedema. You want to ensure the wound edges can migrate. So you want to make sure you don't have epiboly, which is rolled edges or calluses or debris on the edge of the wound, so that the keratinocyte, the cell that covers over the top of the wound, can migrate. If they're rolled edges, if they have callus on it, the keratinocytes cannot come out to close your wound. You want to address nutrition and hydration and mitigate the comorbidities. And with diabetes, it's blood glucose control, blood glucose control, blood glucose control, blood glucose control, blood glucose control. I am not seeing the level of blood glucose control specifically in long-term care that we need for even these wounds to heal. If your blood glucose is over 200, if your patient's blood glucose is over 200, protein synthesis is not going to take place. We've got to keep those blood glucoses low. I've had long-term care nurses tell me that they had the blood glucose at 250, 300, 350, 400, 400. I cried the day the nurse said, my doctor said, don't call me unless the blood glucose is over 500. And I literally cried that day for our patients and for our nurses who are getting messages like that from their providers. eschar, tread carefully. If we have stable eschar here, this is stable eschar. It's attached 360 degrees around. And let's see, what stage is this? Let me know what stage this is, please. So the assessment of that ulcer with dry stable eschar should be performed at each dressing change and is clinically indicated to detect the first signs that they're developing an infection. Now, this is stable eschar. The person has no functional goals. They're not getting out of the bed. They're not going to start walking again. They are not going to wear shoes. So we're going to paint it with betadine to keep it dry so it won't separate. And it's still a stable eschar. This person's, I think they're on palliative or hospice care. So curative care is not what we're going to do for this person. And let's see, what did we get for our stage? And our stage on this is unstageable. That's right. This is stable and stable eschar on an unstageable wound due to eschar. So it is unstageable. Thank you very much. Good job, Wes. So you want to assess the eschar daily per shift and document the condition of the eschar. In some people, if they have blood flow, the eschar, if they have blood flow, if they have adequate blood flow, sometimes this eschar will begin to release and actually peel up, and the keratinocytes will go underneath the eschar and will end up covering it. And so you trim it back. Don't pull all that eschar off. Just trim what's loose and that's come up, and where you can see the new epithelial cell underneath, and you can trim it over time. Don't cut it off, and don't have the provider debride it. And before you do any of that, you make sure you have adequate blood flow. All lower extremity wounds must have blood flow studies. All lower extremity wounds must have blood flow studies. And you're going to assess this every day. Coding tips from MDS. Section M says stable eschar, which is dry, adherent, what you just saw on that previous slide, intact without erythema, or fluctuant, which means squishy, soggy, boggy, on the heel, serves as the body's natural biological cover and should only be removed after careful clinical consideration, including ruling out ischemia. And this is in your MDS 3.0. The MDS, if you're in long-term care, oh my goodness. And the OASIS, if you're in home health, excellent wound education. Excellent wound education. And so does F686. You need that information if you're working in long-term care. So you want to rule out ischemia and consultation with the resident's physician, nurse practitioner, physician associates, or clinical nurse specialist if allowable. So you only take off stable heel eschar if that person has functional goals and you can do it safely, which means that they have to have blood flow also so that wound can heal. So in summary, the keys to improving pressure injury prevention is simplification and standardization of your pressure ulcer injury specific interventions with clear, consistent documentation. Involvement of a multi or interdisciplinary team. I actually prefer the term interdisciplinary, which means that we're talking to each other, whereas multidisciplinary, we can still be in our silos. And that's one of the banes of every one of us that work in healthcare is when we're staying in our silos and we're not communicating with each other. That's a problem. You want to have designated, you want to have the multidisciplinary, interdisciplinary team. You want to designate your skin champions. There are some people that love to do this. Find them, train them, educate them, certify them in wound management. And it'll go a long way. One of my companies that I work for, they paid for me to get my doctorate. And I gave them 5 years of my life to pay back the money for the doctorate. And I stayed another 10 years because I love the company. So this is something to think about. If you're a leader in one of these companies, no matter what your care setting is, invest in your people and then have an agreement with them that they have to pay you back if they leave before they've paid back the money that you did for their advanced education, be it a certification, be it another degree, whatever it might be. There are ways to do this and then keep your people for a while. It's just something to consider. You want to have your skin champions, ongoing in-depth education. And thank you all for being here because you're here and you're getting educated. I'm so grateful for that. On specifics to the heel and other pressure ulcer sites. Wound prevention and management is a massive amount of information to get under your belt to know how to do this well. You want to use recognized clinical practices to structure your prevention programs, such as the National Pressure Injury Advisory Panel, the Wound Ostomy Continence Nurses Society. The WOCN has wonderful protocols that you can use, and templates that you can use. You need to have a sustained, this is your QAPI program. If you're in long-term care, QAPI, your sustained audit and feedback for promoting both accountability and recognizing success. So that's it. Woo, 255 where I am in Texas. If you have questions, Jacqueline's going to go through and help me with that. And we want to just mention to you that next month, we're going to be doing pressure injury imposters, one of my favorite talks to do, pressure injury imposters, because we're reporting a lot of things that aren't pressure injuries, as pressure injuries. We don't even know what the data is. People say, oh, the data, pressure injury and data. We don't know. We're reporting so many things that aren't pressure injuries as pressure injuries. We have no idea what the data is on pressure injuries. So if y'all like to come next month, we'll have a really good time. Jacqueline, what you got for us?
Yes, ma'am. One question we had from Jennifer, she asks, what's your opinion on providers deciding that heel ulcers are venous in etiology?
I don't know what to say. There are no heel pressure injuries that are venous. Venous, well, what would I say? I would say that they need education. That's what I would say.
Mhm. Mhm.
Yeah,
Okay.
because there's no heel pressure injury. There's no heel um, venous leg ulcers, venous heel ulcers. There's no such animal. Yeah.
Mm, yeah.
And if you
Okay.
want to talk about that some more, let me know. If you have more caveat for that question, let us know. But there is nothing such as a heel pressure injury. So I mean, heel venous leg ulcer, heel foot leg or venous foot ulcer, and so that person does need some education.
Okay. Nelson asks, I tend to use betadine swab sticks for the DPI and stable eschars twice daily. Is that still an appropriate treatment for closed DPI?
I don't think it's going to make any difference one way or the other, Nelson. That deep tissue pressure injury, what it has to do is it has to go through the process of declaring and demarcating itself. And if it turns into eschar, now what the betadine will do, it'll keep it dry and it'll turn into its nice hard dry eschar. So there's nothing wrong with doing that. But once it does, it gets dry. Now you have to remove it. The eschar is going to have to come off unless it's on the lower extremity, on the heel. If it's someplace else on the body, the eschar is going to have to come off. And if it's on the leg, any place on the leg, we have to have Doppler studies first before we take off eschar, especially stable eschar. But I applaud you for putting on your betadine and keeping that eschar dry. Once that deep tissue pressure injury declares itself, it's 100% eschar. When that eschar comes off, it's going to either be a stage 3 or a stage 4 when it comes off. Thank you for that question.
Okay. In a similar vein, Naomi asks, would you paint with betadine, then cover with a 5-layer foam, or leave the dressing off?
Well, the foam is to prevent pressure injuries. So the horse is out of the barn. I'm in Texas. The horse is out of the barn. So it's too late now to use your 5-layer foam. So I would just continue to paint it with betadine because you're not going to reverse a eschar with foam. All you're going to do with that is you might soften the eschar because part of that foam, that 5-layer foam, the top layer is a thin film with which has helps to keep the wound more moist. If you put foam on top of an eschar that you're trying to keep dry, you literally might start a little bit of debridement and it may get mushy. So I wouldn't put a foam on eschar that I'm trying to keep dry. I just keep petting it with the betadine, which you were doing. Anything else?
Great. Any other questions, anyone?
Oh, somebody says thank you for having that on a tape presentation. Okay. I love it.
Let me
Yes,
just
this
make
was the
sure.
discrepancy we talked about for the heel. All right. You were wonderful, everybody. You did the little quizzes with me. I had so much fun with y'all today. Thank you so much. Take good care, and I hope we see you next month. Thank you, Jacqueline. Appreciate